Welcome to Presidio Health's presentation on urgent care E&M changes effective January 2021. My name is Nikki Bucheri and I am the Director of Coding Services for Presidio Health. As you may have heard, there are major changes ahead for E&M codes in 2021. These E&M changes have been adopted by the American Medical Association CPT editorial panel and will be effective January 1st, 2021. This represents the first major change to any E&M code set since 1997. This will impact office and other outpatient E&M code sets only, and this is the code set that we use in the urgent care. It includes revisions to 9 existing codes, 99202 through 99215, and the deletion of one code, 99201, which is the Level 1 new patient code. It's important to note that there is no change to ED codes or guidelines. So if you're working in a facility that's hybrid, where you have an urgent care and an emergency department, when you're working in the emergency department, your documentation will not change. Those codes remain the same, the guidelines are the same. This applies to urgent care only. CMS has said they are aligning with the changes effective January 1st, 2021, and we expect other payers to follow. So let's first look at the structure of our current E&M levels. Current E&M levels are determined by evaluating the history elements, and this includes the HPI, the ROS, the PFISH, in combination with the number of elements of exam. And to that we add medical decision making. And medical decision making is determined by scoring 3 different elements: management options, amount and complexity of data reviewed, and the level of risk, which is per the table of risk that is contained within the 1995 guidelines. So how is this changing? The biggest change is the counting of elements of history and exam will no longer exist. Instead of that counting of elements, all that's required is a medically appropriate history and exam. And we'll take this history and exam in combination with medical decision making. Medical decision making will still be scored in 3 different categories, but those definitions of those categories have been revised. Alternatively, instead of using medical decision making, you are able to use time. So in review, we have 2 methods for selecting an E&M level. You can use your medically appropriate history and exam in combination with medical decision making, or your medically appropriate history and exam in combination with time. The history and exam are required and must be documented. However, the nature and extent of the history and exam are to be determined by the provider. No more counting of elements. E&M level selection will be driven by medical decision making or time, whichever favors the best appropriate reimbursement. And you can take this on a case-by-case basis. You don't have to make a decision if you're going to evaluate all visits using medical decision making or you evaluate all visits using time. Whichever one favors the most appropriate reimbursement on a visit-by-visit basis. So let's take a closer look at medical decision making. We still have the levels of service 1 through 5. A big difference is there is no delineation between new and established patients for purposes of assessing MDM. Differences in codes are utilized, but the criteria for the levels is the same. There is also a difference in reimbursement, and this is Medicare reimbursement, that new patients are reimbursed at a higher rate. You must meet 2 of the 3 elements of MDM to qualify for a particular level of service. We do have one exception, and that is our level 1 exception. Level 1 can be assigned to an established patient without meeting any MDM criteria at all. This is typically a nurse visit. And then also recall that there is no level 1 for new patients anymore. Code 99201 has been deleted. Let's review the elements of medical decision making. Here are the three that we're familiar with: management options, amount and complexity of data reviewed, and the level of risk. And that's per the table of risk within the 1995 guidelines. These three elements have been revised. So management options has become number and complexity of problems addressed at the encounter. The amount and complexity of data reviewed hasn't changed much in title, but the methodology behind calculating this element has changed, and we'll go through that in more detail. The level of risk has also been revised to risk of complications and/or morbidity of patient management. So these are now our three elements of medical decision making. Before we get too far along, I'd like to take a moment to review the new MDM table. We'll review it in more detail later on, but I wanted to place it here so that you could get a sense of where we were headed, how this all fits together. So here's the three elements that we just reviewed. And these three elements will be individually scored. So the number and complexity of problems addressed at the encounter, the amount and/or complexity of data to be reviewed and analyzed, as well as the risk of complications and/or morbidity of patient management. And two of those three elements of MDM must be met to assign a particular level. So back to our elements of medical decision making. Let's first take a look a little more closely at the number and complexity of problems addressed at the encounter. This element allows us to capture the number and complexity of problems addressed at the encounter with or without a diagnosis being established. A problem can be a condition, illness, injury, signs and symptoms, the patient's complaint. And addressing it means you managed, evaluated, or treated the problem. Your final diagnosis does not determine complexity. As we all know, extensive evaluations are sometimes required to rule out highly morbid conditions, but your final diagnosis turns out to be something not so complex. Likewise, you may have multiple low severity problems that increase complexity due to the interaction of them. Consideration of further testing or treatment, but electing not to proceed due to a risk-benefit analysis or patient choice, that also qualifies as addressing a problem. You do have a few things that you need to watch out for, such as symptoms that are clustering around a diagnosis. Each symptom is not necessarily a unique condition. Comorbidities or underlying diseases, those in and of themselves are not considered unless they're addressed or their presence increases data or risk. So simply listing out all of the patient's past medical history, even if it's something they currently suffer from, and say if they're diabetic, but they're there for a finger laceration and you're not addressing the diabetes whatsoever, we can't count that as increasing the complexity at the encounter. Notation of another provider managing a problem without an additional assessment or care coordination by you does not qualify as addressing a problem. Same for giving a referral without evaluation or consideration of treatment by you, that does not qualify as addressing a problem. Now we will review a portion of the medical decision-making table that is specific to number and complexity of problems addressed at the encounter. First, we have level 1, which again is established patients only, and you'll notice it's marked as not applicable. And you'll see this throughout all of the medical decision-making tables. The reason for this is, if you recall, our level 1 patients are not required to meet any of the elements of MDM. Moving on to our level 2 straightforward visit, the problems addressed are minimal. And minimal is described as one self-limited or minor problem. And a self-limited problem is a problem that runs a definite course and is transient in nature. Our next category for level 3, low. These are patients with 2 or more self-limited or minor problems, or one stable chronic illness. And a chronic illness has an expected duration of at least a year. And a note on stability from CPT. A condition is not stable if a patient is not at a treatment goal. An example here is a well-controlled hypertension in a patient who is not at their treatment goal. They are not stable, even if pressures are not changing, even if the patient is asymptomatic. For the purposes of MDM, the risk of morbidity without treatment is significant. Back here in our low-level category, we could also have a patient with one acute uncomplicated illness or injury. This would be our cystitis, allergic rhinitis, simple sprains also fall here. Level 4, moderate. These are patients with one or more chronic illnesses with exacerbations, progressions, or side effects from treatment. Now, even though their condition is acutely exacerbating and it requires attention, they're not requiring a hospital level of care. We could also have patients with 2 or more stable chronic illnesses, one undiagnosed new problem with an uncertain prognosis. These patients are likely to result in a high-risk morbidity without treatment. An example here would be a breast lump. We could also have a patient with one acute illness with systemic symptoms. This is where pyelonephritis, colitis are going to end up. Or we could have one acute complicated injury. This would be such as a head injury with a brief loss of consciousness. Moving on to level 5, high. So in the high category, we have one or more chronic illnesses with severe exacerbation, progression, or side effects for treatment. So these patients may require hospitalization. Or we can have a patient with one acute or chronic illness or injury that poses a threat to life or bodily function. So here's where we have our MIs, our pulmonary embolisms, psychiatric illnesses with threat to self or others, patients with an abrupt change in neurological status. So now we've reviewed the number and complexity of problems addressed at the encounter. Let's move on and review in more detail the amount and/or complexity of data to be reviewed and analyzed. This element will categorize various types of data from different sources. So let's first review the different sources we may get data during a patient encounter. One is a test. So this might be imaging, labs, psychometric or physiological data. And CPT is looking for unique tests, and they define this in accordance with CPT codes. So an example here is a lab panel. A lab panel being one unique test. So you may order a CMP which contains 14 different lab values, but it's just one unique test. Another example might be a 2-view chest x-ray. It's 2 x-rays, but it's just a 2-view chest x-ray on a bill. So it's just one unique test. Another source may be external notes. So these are records, communications, or other test results from an external physician, facility, or healthcare organization. Another source is an independent historian. So this is an individual who provides a history in addition to a history provided by the patient. and the patient is unable to provide a complete or reliable history. So you're speaking with a parent, a guardian, a spouse, a witness to an accident to get that more complete history. Another category that we will see used within this element is independent interpretation. And this is an interpretation of a test for which there exists a CPT code and an interpretation or report is customary. This does not apply when the provider is reporting or has previously reported the professional component for payment. So in the case of an X-ray, if you're doing the professional read and expect a bill for it separately from your E&M, you can't also count it towards complexity of data. Your interpretation should be documented, but it doesn't need to conform to the usual standards of a complete report for that particular test. The other category that we will see is discussion of management or test interpretation with external providers or appropriate sources. An external provider is an individual who is not in the same group practice, or an appropriate source is a non-healthcare, non-family source involved in patient management. This might be a parole officer, a case manager, a lawyer, a teacher, as long as the person is involved in patient management, but they are non-healthcare, non-family source. Now we will review the portion of the MDM table that pertains to amount and complexity of data. First, we have our level 1 visit, and again, marked as not applicable. Our level 2 or straightforward visit, we would expect minimal or no data to be reviewed by the provider. When we get to our level 3 visit, we introduce this idea of categories. And what we're looking here to support a level 3 visit is a limited amount or complexity of data, which is defined as meeting one of these two categories. So category 1 is tests and documents, and any combination of two of the bullet points below will fulfill that category. One note on a unique test, each unique test may only be counted once. There was a recent CPT assistant that clarified this point, that a provider ordering a test, it's assumed that that provider is also going to review those test results. So that particular test can only be counted once towards either reviewing or ordering. You can't count it twice. Alternatively, you can meet the limited requirement of a level 3 visit by meeting category 2, which is the assessment requires an independent historian. So if you're engaging with a parent, a guardian, surrogate for the patient, you can fulfill this category as long as the patient themselves was unable to provide a complete or reliable history. So documenting the medical necessity of engaging with that independent historian becomes important here. Level 4, our moderate visit, we've expanded into 3 categories, and you have to meet at least one of the 3 categories to fulfill the moderate amount or complexity of data. Now, category 1 here is essentially a combination of category 1 and 2 from above, but you need to meet a combination of 3 items from that list. Category 2 is independent interpretation of tests. Again, these are tests that are not separately reportable. In category 3, discussion of management or test interpretation, and that's with an external physician or other qualified healthcare professional, not someone within your group, and not going to be separately reported. And when you get to level 5, we maintain those same 3 categories, but you need to meet at least 2 of the 3 categories to support that high level visit. So that completes our review of amount and/or complexity of data to be reviewed and analyzed. So now let's move on and take a closer look at risk of complications and/or morbidity of patient management. Risk is the probability and/or consequences of an event. The level of risk is based upon consequences of the problem addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, or hospitalization. CPT states that the 4 levels of risk, which are minimal, low, moderate, or high, are common terms familiar to clinicians. Definitions pertaining to the quantification of these terms is not required due to that shared understanding. Now we will review the portion of the medical decision-making table related to risk of complications. First, we have our level 1 patient, our established patient, and the risk is not applicable. Our level 2 patient, a straightforward visit, carries a minimal amount of risk. The AMA did not provide examples of minimal risk, so we pulled some examples from the 1995 table of risk that we may see, such as rest, gargles, elastic bandages, or superficial dressings. Moving on to a low level of risk. Again, the AMA did not provide any specific examples, so we pulled these from the table of risk. And they include over-the-counter drugs, minor surgery with no identified risk factors, physical therapy, occupational therapy, IV fluids without additives. When we move on to moderate, the AMA did provide examples. Prescription drug management, decision regarding minor surgery with identified risk factors, decision regarding elective major surgery without identified risk factors, and diagnosis or treatment that is significantly limited by social determinants of health. And we were happy to see this addition, the AMA acknowledging the additional risk these patients carry. And finally, level 5 with that high level of risk, the AMA providing these examples: drug therapy requiring intensive monitoring for toxicity, which they went on further to say that these are drugs that require intensive monitoring due to their potential to cause serious morbidity or death. These should be monitored for adverse effect, not therapeutic efficacy. And that could be a long-term or short-term monitoring, but no less than quarterly. Monitoring by way of a history or an exam does not qualify. An example that does qualify would be monitoring electrolytes and renal function in a patient undergoing diuresis. But an example that does not qualify would be monitoring glucose levels for a diabetic patient who's on insulin therapy. That would be monitoring for efficacy. Also carrying a level high risk, an example is decisions regarding elective major surgeries with identified risk factors, decisions regarding emergency major surgery, decisions regarding hospitalization, or you may have that decision to not resuscitate or to de-escalate care because of a poor prognosis. We also wanted to address the new code created by CMS, HCPCS code G2211, that was created to capture increased complexity of care in addition to the E&M level. Now, this code is currently only recognized by Medicare, but we do not believe that the urgent care will really utilize this code. It was created more with primary care in mind, and it specifically says it's not appropriate for use where comorbidities are either not present or not addressed, and or when the billing practitioner has not taken responsibility for ongoing medical care for that particular patient with consistency and continuity over time, or does not plan to take responsibility for subsequent ongoing medical care for that particular patient with consistency and continuity over time. We don't think that this lends itself to urgent care. There's nothing saying that an urgent care cannot bill this. So it's something we'll keep an eye out for, and we wanted to touch on it. Now that we've completed review of all three elements of MDM, let's revisit that MDM table. So we have our three elements here. They are individually scored. By meeting two of at least three elements of MDM, we can assign our level. Let's look at an example. Our history is a 35-year-old, otherwise healthy female presents to the urgent care for the first time with left wrist and forearm pain after tripping and falling over a curb, catching herself on her outstretched left hand. An exam reveals full range of motion. An x-ray was ordered to rule out fracture. X-ray revealed normal alignment with no fracture. In treatment, the patient was advised on how to wrap the wrist with an ACE bandage, rest, and ice. Final impression was a left wrist sprain, and this provider spent 20 minutes in the care of this patient. So keeping in mind we need to meet at least two of three elements of MDM. Our case supported a low number and complexity of problems addressed at the encounter, a limited amount and/or complexity of data reviewed, and just minimal risk. So we met two of the three elements required for a level 3 or a low level. Now that we know how to determine an E&M level based on medical decision making, let's take a look at our other way of determining an E&M level based on time. So we still have levels of service 1 through 5, but in this case there is a delineation between new and established patients. New patients are those that have not been seen by the provider group within the last 3 years, and established patients have been seen by the group in the last 3 years. We do still have a level 1 exception, being there is no level 1 for new patients. Code 99201 has been deleted. So if you're scoring E&M by time and you have a new patient, you must have 15 minutes of provider time documented to be billable. That's a level 2. Let's review some concepts related to time. The time is the total time spent by the provider and must be documented by the provider. This includes face-to-face time and non-face-to-face time personally spent by the provider on activities related to the patient's visit. All time must occur on the date of the face-to-face visit. So this means if you review records the day before a patient's visit in anticipation of their visit, and then also review some lab results the day after their visit, you can't include those times because it didn't occur on the date of the face-to-face visit. Alternatively, if you had reviewed those records just before the patient's appointment, you had the encounter with the patient and then reviewed their lab results later that evening, you can include all of that time because it's all occurring on the same date. Times within the code descriptors are now exact. Previously, they were typical times. Now they are exact. This means minimum time identified in the code descriptor must be met to report the code. New patient visits must meet the 15-minute minimum to be billed based on time, and established patient visits less than 10 minutes will be a level 1 if being scored based on time. You cannot include time spent by ancillary staff, and you cannot include time spent on separately billable procedures. There are a number of activities a provider may be involved with that time can capture. And these include preparing to see the patient, obtaining or reviewing separately obtained history, performing a medically appropriate exam and or evaluation, counseling and educating the patient or the family or their caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals. Again, this is when it's not separately reported elsewhere. Documenting the clinical information in the patient's health record. Independently interpreting tests, again, not separately reported, and communicating those results to the patient, the family, or the caregiver. Or care coordination, again, when it's not separately reported. Also related to time is the concept of the shared visit. So when you have a shared visit, the time used is the sum of the non-overlapping time spent by the providers. And any time that the providers spend together to meet with or discuss the patient should be counted just once. There is also a prolonged service code. This is a new code that's to be used in addition to the E&M level when scoring the E&M based on time. This additional code can be assigned for each 15-minute increment beyond the maximum level 5 visit time, but it must be the full 15 minutes. If you just have 14 additional minutes, that's not billable. It has to be 15-minute increments. And this is the table that gives us the times associated with the various levels of service. So back to our example here of our 35-year-old female who fell, injuring her wrist, ending up with the wrist sprain. When we scored her earlier by MDM, she had met 2 of the 3 elements. So we were able to assign her a level 3, 99203. But if we look at the same visit with time, the provider spending 20 minutes in the care of the patient, she's a new patient, this gives her a level 2, 99202. So in this case, we do better with MDM, and we'd want to assign her a level 3 based on MDM. But let's assume this visit went a little bit differently. We did not order that x-ray, so we also had no x-ray to review, but instead of spending just 20 minutes with the patient, we spent 30 minutes with the patient. So how does this change things? Well, now we're only meeting 1 of the 3 elements of MDM. So we're only able to get to a level 2, 99202. But by time, we're able to get to a level 3. So in this scenario, we would want to bill this patient the 99203 based on time. The only thing that we do need to make a note on time is your times do need to make sense. You can't see every patient for 90 minutes regardless of the problem that they're having. So, you don't want to overuse the amount of time that you're spending with patients. And we'll conclude the presentation here with some documentation best practice tips. You want to be sure you include a medically appropriate history and exam. You want to document all problems you address and how you are addressing them. And again, problems are diseases, conditions, illnesses, injuries, signs and symptoms, findings, all of your patient complaints, and to address them means you are managing, evaluating, or treating the problem. The nature of each problem addressed, so acute, chronic, stable, uncontrolled, worsening. Your review or interpretation of any testing, review of external notes or conversations with patient's family or other providers or other individuals involved with the patient. Your assessment of the patient's risk level. A summary of treatments, and this includes treatments considered but not carried out or you decided against. The total time required for the visit, and if it's a shared visit, the amount of time spent by each provider, including identifying any overlapping time. I hope you found this presentation useful in understanding the new changes that are coming to urgent care as far as E&M assignment goes. I have a couple of links here to the AMA code and guideline changes, as well as the AMA's new MDM table. And as always, you can reach out to me with any questions or if you need any assistance. My office number is there, as well as my email. I wish you a happy new year and good luck with the new urgent care E&M code assignment.